I hope you all are going to enjoy these next 20 minutes as much as I am. I love this topic, and I hope it improves or helps or assists in your practice. I'm conflicted. My passion is really my primary conflict with respect to this issue. I don't think these engagements or entanglements will affect my ability for us to do this. And this is, I really would like us to assess what are the past and the present guidelines that guide you and I with respect to our disqualification considerations or return to play. And then most importantly, I want all of us to do a little introspection and self-examination as to how do you see yourself and your and our responsibility in this space anyway. Do you see yourself fundamentally as a, quote, disqualifier? Or do you see yourself as an educator, informer? And I'm not meaning to set those up as mutually opposed to each other, but you can decide whether they are in opposition as well. I think we ought to step back and say, what is my responsibility with respect to this issue? So help me get a sense of where you currently are wired. When you have an athlete with a genetic channelopathy, would you allow him or her to play or return to sport when she's had a prior on-the-field faint? That's all I'm going to give you, not which channelopathy, but a symptomatic channelopathy in a previously untreated, undiagnosed state. Down they go. Will you be supportive of his or her return to play? How many of you right now are, yes, I would? I'm going to make you vote, so I want to see who you are. How many of you are no way, no how, he, she is done? Okay. How many of you are maybe? Yeah, so we have a lot of chickens in the room. Okay, so now I see the task here of those who are sorely afraid. No, so this is really helpful. What I'm going to try to convince you of those of you who are maybe, I'm okay with that. Of those of you who are de facto no, they're done, they're kicked out, I want to work on encouraging you that from my standpoint, that's the wrong position. And I'll try to articulate why it is. Now, if that has been your position and how you're wired, and you would say, do you just be part of the Just Say No campaign, you are in good company. You are well within guidelines, and you have been for the last 23 years. The original Bethesda conference in 1994, I can sum that up really in one sentence. Unless your heart is perfect, no competitive sports, period. That was the position a quarter of a century ago. And then we upgraded that 12 years ago, both in North America and in Europe with the ESC guidelines, and those are refined a bit. For the channelopathies, these are they. I love this boutique collection of genetic heart rhythm diseases. That answer was easy. You're done. Doesn't matter which flavor, you are done from all competitive sports. Well, almost all. Specifically, for long QT syndrome, let's look at what it said. It said that you are disqualified, that you are advised disqualification. In other words, that's what we do as the caregiver. We advise disqualification from virtually all sports for those who have done something, symptomatic expression, and those who have done nothing, but their QTC is past those thresholds. And for the first time, we actually created wiggle room, recognizing this subpopulation of concealed genetic disease, where we said, you know, if it's only in your genetic code, maybe you can give an okay to play as long as that's not LQT1 in swimming. So there's a new carve-out that started 12 years ago that said genetic-only disease doesn't necessarily have to be disqualified. So what we said 12 years ago in Bethesda is we said, unless your heart is perfect or the syndrome is confined to just your genome, no competitive sports except perhaps Class 1A sports. And hopefully with that, you are by now curious enough to say, well, what is are the exempted sports, the safe haven of Class 1A sports? So me as the disqualifier, what can I give them and offer them? Please tell me there's something good in there. There's not. So this was the task force that was devoted to binning all the sports by their dynamic component, their static component, and after all that entire exercise, none of that mattered because the only thing that mattered is what got put in the bottom left corner. So where everything else was placed was frankly a wasted exercise. Because all we get to offer for the advised disqualified athlete is, but you can do billiards, bowling, cricket, curling, golf, and riflery. That's an interesting list of sports, isn't it? I mean, especially the one that bothers me the most up here is riflery. I'm going to ruin your life, kick you out of what was viewed as oxygen for you, but take up a gun. Just don't come back to my office with it. I mean, riflery. And then does riflery make great sense for long QT2 where the most common trigger is auditory? So evidence-based, I'm not so sure. But you know who's most upset about this list? It's fascinating. Dr. Sharma is. Because of cricket. How dare they put cricket as a safe sport? Obviously, these North Americans don't know how aerobically engaged and active cricket is. So the cricketers are demanding justice that they get put out of 1A and they be viewed at least as equally dangerous as badminton, because that's next door in the 1B category. So this is what we get, and now it's been upgraded. Billiards, by the way, is gone. The newest guidelines now has decided billiards is just frankly too cue dangerous. And it's either the cue ball or the cue stick. But one of those things has made billiards out. But something's in. So we wanted to make sure that we could keep the safe six sport, since you have to be careful when you enunciate safe six. So billiards is out, yoga's in. Now what they didn't do with yoga, interestingly, is they didn't exempt hot yoga and brugada with heat-triggered events. So not everything makes sense, but this is what we have to be practicing within guideline medicine, is to advise disqualification, but keep them enabled to go curling. Now, what's the evidence for this? What I loved about the same time, though, is at least there was consistency in Europe. Europe went retro at this same time. They said, in fact, let's make it much more simpler. Unless your heart is perfect, no competitive sports. Period. You don't even get yoga in Europe. And for long QT, what did they do? They said, I don't care if you're symptomatic, asymptomatic, and look at the cut points for disqualification. Obviously, they're not following those, because if they were truly following these, at least 5 to 10% of athletes would be being censored as having a long QT cutoff that would sanction or merit disqualification. And they said, forget about this exemption clause for genotype positive, phenotype negative. No way, they can't play either. So here we have, for just the channelopathy, we have in North America, concealed long QT, yes, you can play by guidelines. As long as you've never fainted, as long as your ECG is non-diagnostic, you can have an okay to play. Europe said, forget about that. Manifest or concealed, you're done. Gene carriers, you are done. That's quite a dichotomy across the pond, isn't it? So there must be good evidence that would sanction that the presence of this, a positive genetic test result, just that, finding X that marks the spot, would be enough to disqualify you. Because if there's not good evidence, we should call this what it is. And what's that? Genetic discrimination. That's what that is, unless there's good evidence. Well, here's the evidence that was invoked in Europe. AV, something went, shoot. Is the AV person here? Oh. Can you help out? Something's wrong here. I'm just kidding. There's actually no evidence. Okay? So there's no evidence. So, and here's the evidence in America. There's no evidence. So one of the things that was beautiful 12 years ago, at least we were transparent in the guidelines when we said this. Again, this then becomes very different than heart failure guidelines, atrial fibrillation guidelines, guidelines derived from 10,000s of patients. We acknowledge this, that this is based largely on individual and collective judgments and experiences. Do our patients know that? That we're invoking the art of medicine. So now when I disqualify you, I'm being artistic in my recommendation for disqualification. And that as a result of that, this will occasionally cause some athletes to be withdrawn from competition unnecessarily. Too bad, so sad. Because we said it's a controllable risk factor. How do we control that risk? I'm not signing your form to play. That's how we control that risk. And we invoked that this underscored the self-proclaimed wisdom of the conservative nature of these recommendations. In other words, if in doubt, kick them out. That has been the prevailing wisdom. And about this time, or before this time, in our program at Mayo Clinic, we felt like, you know that movie, Big, remember that? Tom Hanks, great scene. He raises his hand in the office. I don't get it. I don't get it. And I raise my hand. I don't get this. Why are we practicing this style of medicine for this topic when we don't practice this style of medicine for almost all the other issues we talk about? Treatment of cancer, life continuation, etc. A lot of etceteras. In other words, why don't we on this issue respect patient and family autonomy and their right to make a well-informed decision based upon their judgment of whether that is viewed as an acceptable risk-taking behavior? Is basketball a risk-taking behavior for a black male athlete at the D1 level? Yes, compared to what? Compared to weekend binge drinking? Compared to what frame of reference? Everything we do are risk-taking behaviors, some more than the other. Are we communicating what is the level of risk that we perceive for that disease? What is the level of residual risk after we have effectively risk stratified and treated you for that disease? And then what is your risk appetite for engaging in said activity? Why don't we do that? In other words, what is that called? Shared decision making. And we said, if we're going to do it that way, we better study this to make sure that we monitor whether that approach of enabling or permitting or not preventing them from being disqualified is ridiculously irresponsible. This has been our experience with these first set of athletes or patients with long QT syndrome. Now, not everybody who comes to see me is an athlete, and I don't care if they're not. I certainly don't try to convert them into an athlete, but many are, and of those who are athletes, a very interesting thing emerges that debunks a myth right away. The mythology in this whole space is that if we give the athlete and his or her family the choice, they will always choose sports continuation. Absolutely a lie. 1 out of 5, 1 out of every 6 of our patients who we talk with, even if I think I have them well treated and that they could continue in the sport safely, they choose self-disqualification. These families are fully capable of choosing self-disqualification. 1 out of 5, 1 out of 6 do just that. So the notion that they can't or they won't is just wrong. Now, the majority say, I'm choosing to remain an athlete. And I currently follow over 350 athletes with a disqualifying heart lesion who have chosen to stay in the game of life. These are the kind of athletes with long QT that we're talking about. That's not relevant. What's relevant is here. Guess where these athletes choose to live in their athletic career? They're just not down there. They're not arriving as curlers. This is the kind of activity we do. And in our program, we ask them, what is your passion? And whatever that sport is, we do not try to change them. I have no goal or drive to say, I will feel better if I can get 1 box closer to 1A. We say, who are you? And the basic question we work with our athletes and our patients is that activity the two O's? If anybody's mind is wandering, no, not that O, but the two O's. Is that activity optional or is that activity oxygen? For the athlete and the family where that activity is utterly optional, they often choose to do something else if the risk meter exceeds. But for that athlete and activity to say, that is oxygen to my child, then we work really hard. Because who are we to say, that actually shouldn't be oxygen for your family, because that's not oxygen for my family, or how I'm wired as the physician. So we let them do what is their love to do. And interesting, look at these. One might argue that for long QT syndrome, these are the highest risk ones, because when is the greatest expressivity of long QT? Prepubertal boys. So we have a lot of at-risk individuals in this cohort. And we have a lot with the exercise-triggered version of long QT, which is flavor number 1. So it's not as if we have a non-risk cohort. So for those who chose to replay, the answer is 1. 1 athlete in 650 athlete years. Our current rate is about 1 per 1,000 athlete years of having a non-lethal event. Badness, tragedy in 17 years for all of our athletes with any of their genetic heart diseases, 350, 400 athletes and counting, remains at 0. Now, if you truly embrace shared decision making, when that number shifts from 0 to 1, and we do have that tragic funeral, our answer cannot change to, now I'm a disqualifier, that was enough. Because shared decision making and autonomy is still autonomy regardless of the outcome. Thankfully, it has remained at 0. Now for that 1 athlete, this was no surprise. He was 11. He had a very long QT interval. He starts with cardiac arrest at kindergarten, and he's received 2 VF terminating ICD shocks while warming up to play soccer and while playing baseball. He's actually had 3rd. You want to know where the 3rd one occurred? Interested? Interested? Yeah. County fair, girl runs up behind him, grabs his cotton candy and runs off with it. Down he goes. So if we're going to do justice, we need to kick out soccer, baseball, and going to the county fair where there are girls. Okay? So that was a risk-taking behavior as well. So when it comes to athletes with long QT syndrome, I would like to submit that the challenge for this disease is not preventing their sudden death. When this diagnosis is made correctly, evaluated and risk stratified appropriately, and treatment program established carefully, death should not happen. The challenge is helping them to live and thrive despite their diagnosis. And I would submit that the same challenge is true for many of the genetic heart diseases and the other diseases for which we flag with our screening programs. The same is true. The guidelines are starting to shift. As a result of that observational experience, 4 years ago, the HRS, ERA, APHRS guidelines about the management of patients with the channelopathies, they changed the tune to a class 1 recommendation now from you're done to if you're an athlete with long QT and you want to stay an athlete, you should be seen by the right person. That's a complete shift from, if you have this diagnosis, you're disqualified, next question. Then the guidelines have shifted again most recently in the latest. This is now Bethesda. It's not called Bethesda, but this replaces and is the current North American document that guides us on eligibility recommendations for a variety, all kinds of heart diseases. And what did we do in Task Force 10? We removed the banishment. The de facto disqualification is gone. And instead, focusing on these 3 channelopathies in particular, we put forward as Class 1 recommendations the following. We reiterated the 2013 position of Heart Rhythm Society that says, that athlete, deserves to be seen by the right kind of cardiologist. Second, we said that if you've been diagnosed, there should be a 3-month hiatus. Where did we pick 3 months? Why did we pick 3 months? We needed a pause. We should have a concussion-like protocol mindset. You get nailed with a concussion, you don't get back in the game next day. You don't get back in until you're cleared and released. And we needed to have the same kind of pause so an evaluation could take place, so that counseling could take place, so that a treatment program could get established, and so that the family would have time to have a well-informed decision to mature. Can that be done in 1 week? Of course. Can it be done in 2 months? Sure. But there needs to be a pause rather than you got flagged yesterday in your ECG screening program with your QTC of 550. Have fun playing tonight, but get this checked out in the future. That's wrong. There needs to be a pause. The second thing we said is we reiterated that over all this time, there's still not a single shred of evidence that says a patient with genetic-only disease is at significant increased risk. So we said if you have gene-only disease, you have an okay to play. Then even for long QT patients who have symptomatic disease or electrocardiographically manifest disease, that you actually can be considered a return to play. Class 2, but that the disqualification per guidelines actually was removed. Brugada syndrome, we removed it altogether and said, you know what? That was caught by crossfire. There never was any evidence, there still is not any evidence, that an athlete with Brugada syndrome is at increased risk. And for CPVT, by guidelines, we said of the channelopathies, this is probably the most twitchiest, where sports and CPVT may not be a good idea. But since those, we actually published our first experience with CPVT, and we've shown in that series that our athletes with CPVT, their event rate, non-lethal event rate, is actually lower than our non-athletes with CPVT. So we think that even a well-treated CPVT athlete could safely re-engage his or her sport of choice as long as they were well-informed and followed the drill about the precautionary measures. So let me summarize the 2015 statement. It's no longer, if in doubt, kick them out from 25 years ago. It is really more not, your heart doesn't have to be just perfect. It doesn't have to be confined to just your genome. It really is about being well evaluated, well risk stratified, well treated, and well informed. And unless none of those have happened, then you should be disqualified. In other words, shared decision making has finally made its way to patients with this issue and these diseases. And the shared decision making has been more formally expressed in last week's article that Aaron led in this. And if you're interested in a read, and if you embrace this paradigm shift, you're going to love this. If you don't like this, you're going to be wishing that why can't we just kick everybody out, because that was so much easier. That was a 5-second drill. You're done. Next question. So let me leave you with this. We have to keep studying this, and you saw this from Kim. We are studying this. We're now 2 years into lifestyle and exercise for patients with long QT and with HCM. We have over 1,000 patients with each disease enrolled, one of the largest enrolled studies for both of these lesions. And to date, there's still not a single signal of excess risk in those who are the most active. So who says I can't play anyway? Let me leave you with these take-home points. I think we should acknowledge philosophy and art trump science and evidence as the underpinnings of these guidelines. Second, that athletes and their families have the right to know the evidence or the lack of evidence that's going into our disqualification recommendation. I would suggest that the past guidelines are not only too strict, but they frankly advocated genetic discrimination, and we should be appalled by that. We certainly have observed over and over again that families and the athletes and their families are fully capable to choose to disqualify themselves. And when they do disqualify themselves, they get along so much better in quality of life than the athlete where you and I kicked them out of what was their oxygen. And certainly for long QT and CPVT, we've shown that those who've chosen to remain an athlete, that their non-lethal event rate has remained extremely low. I think we should then, in light of that, ask ourselves the following. I think fear of malpractice liability is the elephant in the room that most clearly distinguishes our competitive sports recommendations from our recreational ones. Because what we really have said, anything that you don't need my signed release to get back to, I want you to keep doing. Do backyard basketball, stay active, get your 30 minutes in a week and so forth. But you need my signature? Too dangerous. And second, the role of a disqualifier is a 30-second conversation, and it won't use all 30 seconds. Whereas this role of coming to a shared decision-making process can and does take hours. This is not a quickie. And then last, I think we really then need to turn our attention and ask ourselves, am I the right person to be the facilitator for their return to play? I've told our junior faculty that you should never, at this stage of your career, be the one to restore an athlete with known sudden death predisposing genetic heart disease to that sport of choice. That would not be wise for you at that stage of your career, because now the onus and the responsibility if something goes wrong and tragedy occurs is not that they were allowed to play, but who was the one who did the evaluation, the risk stratification, and the counseling and the consultation to enable that family to come to a well-informed decision. And how was that process documented? Not sure that that's a place for somebody young in the art of medicine to navigate. Then finally, I'm asked, when are sports not worth the risk in my own worldview? And I have concluded that when a well-informed athlete and his or her family conclude it's not worth the risk, then it's not. Or when the data clearly compels such a conclusion. And one might argue that compelling such a conclusion is emerging for the disease arrhythmogenic right ventricular cardiomyopathy. But having said that, do I disqualify athletes with ARVC just because they have ARVC? Absolutely not. Shared decision-making still works for there. I still would conclude that when they are well-informed, the vast majority of those ACM athletes choose to give up rowing, cycling, and so forth. But do they have to give up every sport, which is suggested? I don't think so. Well, I hope you've enjoyed this. I hope it's given you some ways to think about how you and I see ourselves as physicians and caregivers in this space. And I've loved being part of your program today, John. Thanks a lot.